So the risk assessment for this patient includes what risk factors for aggressive disease are present. This would include a larger than 2 centimeter diameter, a greater than 2 millimeter depth of involvement, a poorly differentiated tumor, one that is eroded, having no perineural disease in a single biopsy is not definitive because biopsies are subject to sampling error. So before I would say there's no perineural involvement, I'd want to have more information, and I would get additional biopsies to see if that were the case. In terms of staging disease and staging classifications, I am not a huge proponent of using the AJCC staging criteria for CSCC. I think that it's more important to determine whether it's locally advanced or metastatic disease for purposes of consideration of systemic therapy. And that's the decision process in inclusion criteria in the phase 2 registration study. It's not by stage, it's by whether the patient has locally advanced or metastatic disease. And locally advanced disease we know is disease that's failed 2 or more prior surgeries, one that has low confidence of obtaining clear margins, one where there could be substantial morbidity or disfigurement involved. To me, that's far more important. The AJCC and Brigham Women's criteria might be better for communicating to other healthcare providers in terms of a multidisciplinary management of the patient for other modalities, more, in my opinion, for surgery and radiation, less strict importance in immunotherapy. So it's important to have multidisciplinary evaluation of patients, and the best venue for doing so is a multidisciplinary tumor board, a multidisciplinary conference for evaluation and discussion, where there are physicians from each discipline present. The case can be reviewed in terms of the photograph, the imaging, the labs, pathology report, and there can be a discussion started. And the physicians from each specialty can voice their opinion and then come up with a consensus in terms of the best way forward to treat the patient. These decisions about how to move forward with a patient with advanced CSCC, they're not necessarily clear-cut. I think that having a therapy that's shown to have a good response rate that's very tolerable means that it should be a consideration in all of these patients. There are patients that don't want any life-threatening risks, and they believe that a large surgery, even with some disfigurement, may be a better fit for them. This might be where they just want to get on with it, and they don't want to come for every 2-week, every 3-week, or even every 4-week infusion or other administration, and especially over a longer period of time, that they do want to know that this potentially morbid surgery with or without radiation is going to give them a high cure rate, because without a disease cure, it's harder for patients to want to go through that kind of change and that kind of consequence deficits